All right. And then we have like a minute to let people in. We can let them in early. I think we're all ready. There we go. So we'll just wait a couple of minutes for people to join us. Hi, everybody that's joining us. We're just waiting a couple of minutes to let everybody jump on the call here, and then we'll get started. And while we're doing that, we're going to do just a couple of housekeeping things. First of all, I'm Kristen, the Executive Director for the Epilepsy Foundation, and I'm joined tonight by John, who's also helping me, and Dr. Elizabeth Felton. The webinar tonight is being recorded. All of our attendees are not on camera, or there's no, you can't talk either. You can utilize the chat function down on the bottom of your screen and the Q&A function as well. We will be monitoring those questions throughout the webinar tonight. So please feel free to ask those questions even while Dr. Felton is talking. We can ask those at the end. And if you think of any questions after the webinar, definitely feel free to send us an email at our connect at epilepsywisconsin.org email. And John, I think will actually he can stick that in the chat for us when he gets a moment. And thank you guys, everybody, for joining us again. Welcome to our second, topic in our Women in Epilepsy month of virtual meetups. Tonight, we're going to be talking about hormones as our main topic. And again, I'm Kristen, for those of you who don't know, the Executive Director for the Epilepsy Foundation, and joined by John. John, would you like to say hi?
Hello, everybody. Work with Kristen and mostly work with clients, just helping them and new clients and things like that.
Wonderful. And Dr. Felton, if you'd like to introduce yourself. For those of you who joined on the first call, are probably very familiar with seeing you and hearing you, but we might have some new people tonight.
Sure. Hi, everyone. I'm Elizabeth Felton. I am a neurologist at UW Health, University of Wisconsin. I'm an epilepsy specialist, and I have special interests in treating women with epilepsy and then also in the ketogenic diet for adults with epilepsy.
Wonderful. Thank you so much. And Dr. Felton, do you have screens to share, that kind of stuff? Okay. So when you are ready, we are ready. And again, everybody definitely feel free to ask those questions in the chat or the Q&A down on the bottom.
Okay. Hi, everyone. Thank you for joining tonight. This is part of a 4-part series. Let me get to my next slide here. There we go. 4-part series on women with epilepsy this month. Last week, we talked about treatments. This week, we're going to talk about hormones. And then the next 2 weeks will be done by Dr. Ann Josiah, and she's going to talk about contraception and pregnancy. And so I hope that you will attend the other ones as well, even if they're not something that's relevant to you right now, it may be in the future. And so here we go. All right, so today we're going to talk a little bit about the concept of catamenial epilepsy, and I'll define that in a moment. Talk about how hormones can impact seizure patterns, and then sort of talk to you how to identify these patterns and how to talk to your doctor about it. And then we'll talk about some possible treatments. Okay, so women with epilepsy have been shown to have higher rates of menstrual and reproductive function compared to the general population. There's a lot of reasons for that. Some of the sort of proposed etiologies include the number and type of anti-seizure medications that are used, psychosocial factors, depression, type of epilepsy, and even the location of where the seizures are coming from in the brain. And we know that reproductive hormones fluctuate over the course of the menstrual cycle and modulate brain excitability. And it seems that this also impacts seizure patterns in some women with epilepsy. So catamenial epilepsy was first described in the mid to late 1800s. So this concept has been around for a really long time. The word is derived from the Greek word katamenos. And basically, we have these cyclic variations of reproductive hormones over the course of the menstrual cycle, specifically estrogen, which just kind of put simply is pro-seizure, and progesterone, which is anti-seizure. And this pattern is also called catamenial seizure exacerbation. And I'm just going to pause here for a minute, because when you hear catamenial epilepsy, you may think that that means that this is a specific type of epilepsy, and that this is women that have this only have seizures during this time of the month when there's these fluctuations in the hormones. But really, it's more of a trigger for seizures. Women with catamenial epilepsy can have other triggers as well. And so some have said that we should probably call it more catamenial seizure exacerbation. Although if you look it up, you're going to see mostly that it's called catamenial epilepsy. And so it affects about a third of women with epilepsy, more common in women with focal epilepsy, which means the seizures are coming from a specific area in the brain versus generalized epilepsy, which is where seizures are occurring over the whole brain at the same time. It really is under-recognized by both patients and neurologists. And I think there's a few reasons for that. It really does take some time and effort on both the part of the patient and the neurologist to identify the patterns. And so, some women will realize they have this pattern because they'll come to me and they'll say, every time I have my menstrual cycle on day 3, I have a seizure. So obviously there's some pattern there that they can tell. But as you'll hear in a moment, some of the patterns are not always right at the perimenstrual time. It can be during ovulation, and not all women realize when they're ovulating, or it can be during the time between ovulation and menstruation. And particularly if women have irregular menstrual cycles, it can be difficult to tell if seizures are happening in this pattern. So it can be difficult for patients to identify. And then on the part of the neurologist, it really requires going through seizure calendars of women over multiple months to be able to tell if that pattern is there. So you can't just eyeball it, like look at if a woman has tracked their seizures and their menstrual cycle, it's not something that you can just eyeball. Some of the caveats are that seizures can still occur at other times of the month. So a woman who has a catamenial seizure pattern or exacerbation may have more seizures during their menstrual cycle, but they can have them, scattered throughout the month as well. And other triggers can still cause seizures. So it's not just these hormone fluctuations. It can also be due to our other typical seizure triggers like stress or infection or sleep deprivation, for example. So now I'm going to talk a little bit about the menstrual cycle. So it's typically a 28-day cycle, but the range can be from 24 to 35 days. Day 1 of the cycle is when menses begins, when there's some bleeding. Day 1 through 14 is called the follicular phase. And day 14 is when there's ovulation. And then it's always 14 days from ovulation to menstruation. And that day 15 through 28 is called the luteal phase. And so I have a kind of a picture of this on the next slide. So if we look along the x-axis here, this is days of the cycle. So, day 1 is when the menstrual cycle begins. Then there's the follicular phase. Day 14 is when there's ovulation. And then the luteal phase followed by, kind of cycling through again to menstruation. And hopefully you can see my cursor here. I realized I was using my cursor on the other screen. There's this right before ovulation, there's this increase in estrogen. And I had mentioned earlier that estrogen can be pro-seizure. And so that can be a trigger for the peri-ovulatory type of seizure exacerbation due to this spike in estrogen. And then right before menstruation, there's this precipitous drop in progesterone, and progesterone is anti-seizure. So that goes down, and that can also be a trigger for seizures. And then some women, particularly women that have irregular menstrual cycles, will have this pattern where they have seizures sort of in that in-between time between ovulation and menstruation. A lot of times when there's an irregular menstrual cycle, they're actually not ovulating regularly. And so that you're not getting the same hormone fluctuations that we typically see. Okay, so this is kind of saying in words what I was trying to describe, these three catamenial patterns. It's called the C1 pattern, is perimenstrual, right around the menstrual cycle. Usually it's the few days before and few days after. And this is the most common type, and it's due to progesterone withdrawal, or that drop in progesterone that I showed you on the prior graph. The C2 pattern is the ovulatory pattern, due to that spike in estrogen that you get right before the ovulation occurs. And that typically is centered around day 14, which is when ovulation occurs. And I realized it's a little confusing because when it has this -13 and -3, it's a little hard to explain, but basically the numbers kind of count forward and count backward. Like, just ignore that for right now. If you have questions about that, I can answer it later. And then C3 is that time in between kind of ovulation and menstruation, when it would typically occur. And these are typically due to anovulatory cycles, or when there's not ovulation. And often these women have these irregular menstrual cycles, and during that time can be an increased time of seizures. So how to tell if there's a catamenial pattern. So it would be important for you to record the dates of your seizures and your menstrual cycle. You can do it on a calendar. I have like physical paper calendar sheets that I hand out in my clinic. You can go online and print off these kind of calendar sheets. You can get a calendar from the store, like one of those wall calendars. Some people have seizure tracker apps. There's a variety of apps you can get on your phone that track seizures. And then I have some patients that just take a notebook and just sort of write down the dates. However you do it is fine. Whatever is going to work best for you. It's just really helpful to have that information. The most important pieces of information are the dates of the seizures and the dates of your menstrual cycle, particularly day 1 when you have the bleeding starting. And we need at least 3 cycles to establish a pattern, and often it takes more to determine that. Particularly in women that are having irregular menstrual cycles, it's a little bit more difficult to identify these patterns. And also, there may not be catamenial seizures every month. I mean, some women, you can go a month or 2 without a seizure. So maybe you have 6 seizures a year, and you're sensing that it's always happening around your menstrual cycle, but you really need to track that so that we can kind of look at that pattern over several months and see if it's present. And then this third bullet on the slide is really something that I would do. So you would provide me that information, and then I have an Excel spreadsheet that I sort of plug in this information in terms of when you're having the seizures and when the menstrual cycle is. And there's a ratio, like a mathematical calculation that's done that looks at the average daily seizure frequency during those target phases, that C1, C2, C3 phase that I talked about, compared to other phases, other times of the month. And if that number is over a certain value, which there have been published studies sort of validating what the ratio should look like, that indicates that there's a catamenial pattern. So again, that would be something that I would be doing with the data that you provide me. So now I'm going to talk briefly about treatments. And I mean, I'll just preface this by saying that there's no one answer to this. And also, most studies that have looked at treatments for catamenial epilepsy have not shown strong evidence for one treatment over another. So most women with catamenial epilepsy, we use standard treatments that we use for any woman with epilepsy or any person with epilepsy. Anti-seizure medications, and then looking at surgery, neurostimulation, or dietary therapies if medications aren't working. So that's first line across the board, including women with catamenial seizure patterns. But sometimes the patterns persist despite treatments, and then we can think about what else we can do. So there are a lot of factors that can impact the treatment decision. So one is which type of catamenial seizure pattern is found. There's some evidence that certain patterns respond better to certain treatments. And that's often about if the menstrual cycle is regular or irregular. So just to kind of explain that, if you have noticed that seizures tend to occur, let's say 2 days before the onset of your menstrual cycle, and you have very regular cycles, every 28 days you have your cycle, you can predict when that is going to occur. You can predict 2 days prior to your menstrual cycle very easily. And so if you wanted to have a treatment, like if I were to say, take this extra treatment starting 3 days before your menstrual cycle until 3 days after, that would be pretty easy to do. But if you have irregular cycles where you can't predict when your menstrual cycle is going to occur, it would be very challenging to be able to say, take a medication starting 3 days before the expected onset of your period. And then another factor, the third bullet here, is whether there are contraindications to hormonal therapy. So for example, if you have a history of a stroke or certain types of migraine, then some types of hormonal contraception may be contraindicated. And then need to always consider medication interactions with hormonal treatments. I had maybe touched a bit on this last week, and that probably will be touched on in future weeks, but some of the like birth control pills can have interactions with some of the seizure medications that you have to be mindful of. So here's a list of some of the treatment options. So progesterone. So this wouldn't be used for contraception, but these are actually like progesterone lozenges, or they come in some different formulations, and they're typically used for 10 days out of the month, encompassing the catamenial seizure pattern. And there have been some studies that this is good for the C1 seizure pattern, which is seizures during the menstrual cycle. Acetazolamide, which is a sort of older medication. It's also called Diamox. It has used for some other indications like idiopathic intracranial hypertension, but it has shown some evidence that it may be helpful in catamenial epilepsy. Clobazam, also called Onfi, is one of our anti-seizure medications, and there have been some studies, actually quite old studies, that have shown that it may be helpful. And then just depending on what treatments a patient is already on, sometimes we can boost up the dose of that during the catamenial seizure exacerbation time. So not all medications we would want to do that with. It sort of depends on which medication and what like your medication level is. But sometimes we can do that. Or if a woman is on ketogenic therapy with like the modified Atkins diet, for example, sometimes we can recommend strategies to increase ketosis during that time. So like essentially having extra fat to try to boost the ketone levels and hopefully prevent seizures. And then hormonal contraception, this is probably one of the more common ones that are used to try to suppress ovulation and menstrual cycling. And so an example could be using Depo-Provera, which is an injection that is done every 3 months, or like a birth control pill. However, we recommend that it's taken continuously. So skipping the placebo pills and not using the types of pills that are like have different amounts of hormone for every week. So those can be like tricyclic birth controls. We don't recommend that. We recommend it where it's a continuous amount of hormone, and then skipping the placebo pills and taking the pill packs back to back. And then I get asked this question a lot, and so I threw it on here. So hysterectomy is typically not a viable option. You know, I have some women who say, you know, I'm done having kids, or I'm not having kids. You know, this has been causing me a problem with my seizures. Can I just have a hysterectomy, which means removing the uterus? So the thing is that when a hysterectomy is done, almost always the ovaries are left in place, and the ovaries generate hormones. And so usually in a woman, if they're getting a hysterectomy for any type of reason, the ovaries are left in place. And with the ovaries, you'll still have these hormone cycles. This is just kind of a graphic of what I was just explaining. So, you know, this is from a publication about catamenial epilepsy that's sort of targeted towards physicians, but I still thought this might be helpful. So, you know, female patient with concern for catamenial epilepsy, documents several menstrual cycles, If it's irregular, then you're thinking about medroxyprogesterone, which is Depo-Provera, or oral contraceptives with withdrawal weeks every 3 to 12 months instead of every month. Or if you have regular menses with a clear catamenial pattern, can either try the progesterone lozenges if it's a C1 pattern, or if it's one of the other patterns, you can try some of these medications that I mentioned, or increasing their regular medication. So now I'm just going to touch for a minute on hormones in pregnancy. That's going to be covered a little bit more later this month, so tune in for that. Dr. Josiah will be covering pregnancy. But put briefly, often seizures are improved during pregnancy. You're not getting those same hormone fluctuations with estrogen and progesterone. And so seizures do often improve. However, you have to be careful in the postpartum time when there can be some hormone fluctuations. And so I always, in my patients with catamenial epilepsy, when they get pregnant and they may enjoy a nice stretch during pregnancy of no seizures or few seizures, but I try to be very proactive about triggers and sometimes keeping medication doses a little bit higher in the postpartum time to help prevent seizures after they have the baby. And then perimenopause, which is, as a woman gets older and she kind of gets in that transition period into menopause when periods stop, there can be this time when there's more erratic hormone fluctuations and more irregular periods, even if in the past the menstrual cycle had been regular. And so this can be a time of increased seizures. But once you get past that into the menopause, then often there's a decline in seizures. At least, there wouldn't be a catamenial pattern anymore. Prempro can increase seizures, but you can use natural progesterone if needed. This website, My Epilepsy Story, I had mentioned last week, is a nice resource for women with epilepsy. And I was looking at their website earlier today, and they actually had a really good blog post about catamenial epilepsy. I put a link to it here. Maybe once we're done, I'll put it in the chat so you can easily click on the link. I think it's a really well-written overview of the topic. And we'll kind of cover some of the things that I hit on today. So in summary, catamenial epilepsy, more common than recognized. It's important to identify the pattern, so that can be challenging. And so what you can do is just really keep good track of your seizures and menses dates and ask your neurologist if they're noticing a pattern based on what you show them and what treatment options are appropriate. And many epilepsy centers have physicians who sort of specialize in women's issues. And so, at UW Health, and Dr. Ann Josiah and I kind of run the women's epilepsy clinic. And at other centers, there are, people that sort of specialize in women's epilepsy. And not that you have to see somebody with a specialty in that, but if you're feeling like you're noticing something, but you're not getting kind of the answers that you want, or not getting a thorough enough look, you can always ask to see somebody with that specialization. And then I just wanted to remind once more about the upcoming virtual meetups. And then I really wanted to allow time for questions. So I'm going to stop sharing my slides and open it up for any questions, or maybe there are some already. I'm not sure.
I see a couple. John, would you have questions?
Got one here. First one I'm seeing come in is the following. Several years ago, my seizures ended, but were known as catamenial seizures. Could the depot shots I've been getting have anything to do to stop the pattern of the seizures?
Yeah, so Depo-Provera shots often do help with catamenial seizures. So basically it kind of suppresses ovulation and sort of stabilizes the hormone fluctuations, and often leads to an improvement. That seizures don't necessarily always completely go away, but many women who try the Depo-Provera do have some benefit. There are some pros and cons about Depo-Provera. So long-term, it can affect bone health. And so, it may not be something that you would want to do for like 30 years, for example, but for some period of time, or at least like a trial to see, like, would this help my seizures? If I did this, I think it's worth using. If somebody's on Depo-Provera, I mean, I really check all my patients for vitamin D deficiency, but I think just bone health is a little bit of a tangent, but bone health in women in epilepsy is something that's very important. And in part because of like these treatments that can affect, so like the Depo-Provera, like I'm not prescribing that, but maybe I'm recommending it because of the catamenial seizure pattern. And if that's going to affect bone health in my patient, I want to be mindful of that. And so taking a multivitamin or a vitamin D plus calcium, I think, is important.
Can you tell us what's the importances of vitamin D specifically? I hear a lot about that.
Yeah, so vitamin D and calcium are important for kind of the strength of your bones, and also exercise. So weight bearing exercise is important as well. And as you get older, your bones can start to become a little bit thinner, and people can get osteoporosis or osteopenia, which are basically weakening of the bones. And vitamin D and calcium can help to maintain bone health. And some of our seizure medications can actually impact the metabolism of those. Like, so for example, I had mentioned it last week, I think valproic acid, which is Depakote, can affect vitamin D metabolism, and then it can lead to deficiencies, and then, impact on bone health. And so bone health is important just in general, but also, I mean, everyone should have, an importance of bone health. But like when I'm thinking about my patients with seizures, and particularly ones that are having like generalized tonic-clonic seizures or seizures where they fall and are having convulsions, you want to have strong bones so that you don't get fractures and things like that from those injuries.
Okay.
I had a question actually. And so in talking about younger women or children, in the elementary or, middle school ages, where there's a lot of hormone changes, things like that going on. Do you have recommendations as far as, tracking some of that, as far, that can be just an up and down, unpredictable time?
Yeah.
Could you potentially touch on some of that?
Yeah, that's a great question. I mean, I've had many patients. I mean, I'm an adult specialist, and so I usually am, seeing people age 18 and up, although I do have some patients that are younger. But I commonly do hear this story that my seizures started around the time my menstrual cycle started, in my early teens or something like that. And, I do want to emphasize that the hormone fluctuations are not like the cause of the epilepsy. It's more of a trigger, but everyone has their first seizure at some point, and oftentimes there is a trigger. Oftentimes, they'll say like, oh, I had just had an all-nighter and I was under a lot of stress, and then I had my first seizure. So most people who do an all-nighter and are under stress don't have a seizure. Like, it wasn't the all-nighter and the seizure that's like the cause of the epilepsy, but it was a trigger. So similarly, I have many patients that say that they had their first seizure around the time that their menstrual cycle was starting, and like maybe like early teen years or something like that, or preteen. And so that could certainly be a time when the cycle is first starting that it's irregular. Even if later on, when they're older in their 20s and 30s, it may become more regular, but it can be very difficult to predict. And so, my recommendation is the same, is just to really keep track of the menses and the seizures. Sometimes, in, teenagers, young teens, they will do, Depo-Provera or hormonal contraception more for the purpose of regulating the menstrual cycle, not for like they may not be sexually active or whatever, so it's not really for that reason, but it's more for this regulating the cycle and trying to prevent these, fluctuations that are causing seizures. But again, I mean, going back to the point I had a moment ago, you may not want to start Depo-Provera at age 12 and continuing it until you're 50, like that would be like, I feel like unreasonable. And so thinking of like other ways to treat it, I think is important too.
Absolutely. Absolutely. So in thinking about, just a diagnosis in epilepsy in general, we always talk about, 2 or more unprovoked. is there a
Mhm.
potential a doctor or physician would consider this type of seizure activity provoked?
I don't think so. No. I understand what you're saying. So usually I think I'm thinking about provoked seizures as being, alcohol withdrawal, for example. If somebody is like an alcoholic and then is drinking a lot and then suddenly stops, they can have an alcohol withdrawal seizure. There are certain drugs that can trigger seizures, or even a febrile seizure in a baby. If they have that, the fever is kind of the trigger. But with the catamenial seizure exacerbation, I don't consider that as a provoked in the sense that you're using it.
No, thank you. I just wanted to make sure that there was kind of, just a distinction between the two.
Yeah.
Because I think there potentially could just be some confusion there, and not, maybe not right now with anybody that's listening, but just in the general public that could be, listening later on.
Yes, no, absolutely. And I think sometimes it gets tricky, like with the words that we like throw around, trigger, provoked, like it kind of seems like a similar word, but
Sure.
in the definition of epilepsy, it's talking about provoked seizures. And so in that sense of the word, they're talking about things like alcohol withdrawal, drugs, and febrile seizures, things like that.
Sure. No, wonderful. Thank you. John, I see another question. Did you see that one?
I did, yes. Can these treatments be used for women who have a different type of epilepsy?
So some of the treatments that I listed were things like, so yeah. So I guess it depends what you mean by different type of epilepsy. So if a woman does not have a catamenial seizure pattern where they're not having seizure exacerbations due to their menstrual cycle, then I think that most of these treatments would be unnecessary for that purpose. However, some of the treatments I listed, like clobazam, which is Onfi, is commonly used for a variety of types of epilepsy. And I often recommend hormonal contraception or Depo-Provera for my patients with epilepsy to, if a pregnancy is not desired, I do recommend using that. But I wouldn't expect it to necessarily impact the seizures in that case, if that's not a known trigger. And if I didn't answer your question, please feel free to put something more in there.
I know there's other topics we're going to discuss later on in the month, with pregnancy and contraception and things like that. I know those are really, we get a lot of questions on those as a foundation. And I'm sure you do as, a practitioner as well, and seeing, a variety of different patients. In the process, if you're thinking about that's, you're being treated for this type of epilepsy and these types of seizures, is there, like a different schedule or things that you should be doing if you are wanting to get pregnant or wanting to get pregnant later? We often, there are some drugs that are not, desired to, to be taking while you are pregnant. So I think there might be some questions there too, or will we answer those later on in the month?
Yeah, no, I mean, I'm happy to touch on it here. That's fine. So yeah, I mean, in terms of like pregnancy planning, for sure, there are some medications that we prefer over others. And so if I have a woman with epilepsy come to me with like a new diagnosis of epilepsy and we're starting from scratch with medications, there are certain medications that I'm going to choose over others for sure. Similarly, like if a woman comes to me and they're on valproic acid or Depakote, and maybe they've been on it since childhood. It is sometimes used for childhood epilepsy, and they're thinking they may want to become pregnant. I'm going to be working to get them off that medication. I usually recommend to my patients, I mean, at most or almost every visit, I kind of touch on some aspect of pregnancy or contraception, if they are of childbearing potential. So if they're at an age where they could become pregnant, even if they're not actively trying to become pregnant, I usually touch on these topics. And I'm reviewing their medications to make sure that they are on some of these safer ones. And if they're not, then I try to give some counseling about that just so that they're aware of that. There's also interactions between some of the seizure medications and hormonal contraception, so making sure they're aware of that they might need to use like a backup method of contraception. And then also I recommend that all my patients take either a prenatal vitamin or folic acid, like a separate folic acid supplement. And depending on the meds that they're on may determine the dose that I choose of the folic acid. So usually between 1 and 4 milligrams. Now, about kind of tying it back to the topic here, your question, so say I have a patient who does have a catamenial seizure pattern and they are on Depo-Provera or some continuous birth control, and that has really helped their seizures. But now they're like, well, I want to become pregnant. I want to get off this birth control. I don't want to take this anymore because I want to become pregnant. Then we have to watch really carefully as they're taken off that, what happens with their seizures. We may need to make an adjustment to, say if they're on some other seizure medications, we need to bump up those doses or something like that, because now they want to have the menstrual cycling because they want to become pregnant. But that is a known trigger. And so we have to kind of balance that and, be mindful of that and make adjustments if needed. Yeah.
No, that's great. It's really informational. I think there's just a lot of, questions I'm sure that we'll get, and you'll get, throughout the month. So, I don't see any more questions.
This will be the time to submit them if you do have any more, everyone. While we're going to do that, I'm just going to put some information in there. This next series would be next Thursday, October 21st at 7 p.m. Once people joined us a little bit later, so I'm going to go ahead and give you some contact information from us as well.
Thank you, John. And if you guys do think of any questions beforehand, definitely feel free to email us at the email that John put in the chat, or you could give us a call too, if there's just questions that you think of and, you don't want to forget them, those kind of things. We'd be happy to take those, during the week. And don't forget to register for the VMU for next week. And also, these are recorded, and so we will be posting them on our website for later viewing. So with that, thank you so very much. Thank you, Dr. Felton. Thank you, John. Thank you, attendees, for spending some time with us. And with that, we're going to say goodbye.
Good night, everybody.
Good night.